I'll set a timer.
Yeah, well, we'll just keep an eye on it. We just shouldn't, by the time it gets to 7, we should be thinking about rounding up, because if urology come on and steal the Zoom, it'll just stop, which will be rubbish.
Would be rubbish. Would be rubbish. Cool. And I'm watching my own self on the live stream, which is a bit strange.
Oh, what, on the Facebook or the?
Yeah.
That's weird.
A little bit.
Hi, Mum.
Everyone can definitely hear us. I hope so. Can you post in the chat if you can hear us?
That's fine. You can tell that people are joining as well. It'd be quite good to know that there's actually, we're not talking into the event. Is that medal thing working for you? Yeah.
Yeah.
Yeah. Is the medal stream working for you?
Yes. Is it working for you?
Not really, but that's probably my Wi-Fi. As long as we know like, somebody can see stuff. Have we got people coming in?
I can see 27 members.
Oh, good.
But no one's posting in the chat.
If you're online, can you post in the chat just to confirm that you can hear and see us and our slides? That would be super useful. Anything?
No, I'm going to try and log in to
Like Facebook, yeah, and have a look. Oh, I've just got a reminder from medals, so maybe that'll work.
Can I send that link to myself?
Following instructions on the event are following link. Link copy. I'm not sure whether my medal link is working.
What does yours do?
Mine just takes me to the page. Let me check.
Well, the number of members is increasing, so people appear to be.
That's positive. Stream.
So people appear to be able to get to this page.
Whether that's just coming from Facebook then. Is it working for you?
Yeah.
Ah, good. Then we can just assume. Unless it's just.
Well, I'm at the moment watching myself through the live stream. Yeah.
Inception.
It's a bit weird.
Oh, John. I think it's working for me now. Oh, yeah, here we go.
Hmm?
Oh, there we go. Thank you to Khaled. And
Excellent. Fantastic. Will the slides be available in this session?
I can see the slides, so hopefully they're. Do you want to try and flip the second
Yeah.
slide? Yeah.
We can do that. We won't make the slides available during the session, but we can make them available afterwards through Medal. That's fine. Right, we'll start in a minute.
Yeah, give it a couple of minutes past.
Yeah.
I'd be at least 2 minutes late. More likely to wait.
How's your day been? All right. Fair enough.
Pretty bog standard.
Fair enough.
To be honest.
This is the sort of banal small talk.
Yeah, like pretending not to look at yourself on the camera. Yeah, it's great. How's your day?
Yeah, it's good. I had a whole zero.
Should we just?
Absolutely wasted.
Should we start? That's our 6.
We'll start dead on 6.
All right.
Fair.
And people are replying on the chat, so I'm going to make the leap and assume that although I can't see or hear anyone, that people can hear me.
Okay. Cool.
Should we start?
Let's start.
That's 6. Let's go. So welcome everyone to our Specialist Foundation Programme interview prep, focusing on the clinical interview, particularly for London, so we'll give some tips on outside of London. And I suppose congratulations are in order, because if you are watching this, that means that you've done incredibly well already to be considered for and offered an interview, which in itself demonstrates that you're a fantastic candidate. So it's a privilege to be speaking to everyone, I guess. That's the right introduction. Yeah. Should we go to the next thing and introduce each other, etc. So apologies for the stitch up on the pictures that Dan did before. So I'm Jack. I'm current AFP in critical care in Barton Health, and I was going through this process last year. Dan?
Cool, and I'm Dan. I'm doing an AFP in clinical neuroscience at King's, and apparently we both really like it. So just what we're going to do is very briefly going to talk through kind of the interview format, and then we'll move on to the main kind of the majority of what we want to talk about today, which is the clinical scenarios and how to go about them, and a few tips and tricks from our experiences. And then we're happy, time pending, to answer questions at the end.
Yeah. I suppose, like I said before, to caveat, we'll focus on London just because the interview format tends to remain the same year on year, and you can apply a lot of the learning from London to outside of London, whereas it's much harder to do the opposite. But if you do have any specific questions for outside of London, let's keep them to the end. And if we can't answer them, we will certainly find someone that can for you. And obviously a disclaimer at the start. So we have been through this process and we're going to give you information that we've been handed down over the years and we've experienced, but we aren't affiliated with anyone delivering the interviews. This is no inside knowledge. This is word of mouth. So please take everything with a pinch of salt. If you want to take into account what we tell you, that's fantastic. But also, if you think it's a load of rubbish, then you may well be right. So interpret it in that fashion, if that's okay.
All right, so I suppose the interview, the actual way it works out on the day is you log in, it's online, and immediately there's preparation time, about 15 minutes once you've done your documents and had all your ID checks and everything. And during that time, you're given an abstract. We're not going to talk about that stuff this week. We'll talk about that next week. You have an abstract time to kind of look through those things. You're not given any of the clinical station information in advance. And then once you've done that, there's a time gap. Based on our experiences last year, there was quite a significant time gap delays between doing your interview or doing your preparation for interview and actually having your interview. So that's something to be aware of, and we'll talk a bit more about that in a bit. And then you have the academic station and personal questions first, followed by the clinical station. So the clinical station really happens right at the end. It's the last thing when you're probably the most tired and worn out and your mouth is very dry at that point. And the panel for both of the stations, academic and clinical, is that you have two clinicians and an additional observer. One of them takes sort of the lead on the academic station and the other one takes the lead, I suppose, for the clinical station. So just talk about,
Yeah, so the waiting room. So the most stressful part of the entire interview for sure. So as you said, there'll be a whole load of admin checks, checking who you are, and then a wait time that can range from anything between 5 minutes for me or quite literally several hours to Dan. Unfortunately, if you're at the back end of the day, I'd imagine the likelihood of you waiting for a while is going to be more. And then you get 15 minutes. And at that time, you'll be given both the abstract, which will tell you how to proceed next week, and the clinical scenario, or rather scenarios more likely. No doubt this will be filled with blind panic and writing down as much information as you can. We're going to give you some tips on how to probably best use this time ahead of the interview. Also, rather nerve-wrackingly, you might well be in a waiting room with several other people and you'll be able to see what they're doing at the same time. Our advice, of course, would be not to look at another person and see how much they're writing throughout. You'll see some people that will spend the whole time scribbling down as much information as you can, or if you're more towards the persuasion of myself, maybe a few highlights and a few circles. It's really your time to do whatever you will. Yeah, I suppose that's as much as I want to say here, probably. So our tips for the prep time. So particularly for the first minute, if you're anything like me and you really wanted this job, you'll be quite stressed and you won't really be able to order your thoughts too much. So our advice would be to read through the entirety of the abstract, which will be, a typical abstract length, a few hundred words that you'll see in any of the major journals, and clinical scenarios which can range from 1 or 2 patients to really up to 5 or 6. And for that, you'll get probably a couple of lines of information, whether that be clinical history, observations, or a specific task that you've been asked to do. This typically reflects an out-of-hours F1 on-call role, which is where your experience from your placements really comes into handy. Our advice for the clinical scenario in particular is to focus on several things. So firstly, prioritization. Which of the patients will you want to see first, and we'll have an activity and how to do that in a little bit. Focusing on patient safety. Think about the key things that might need to be done for each patient. And again, we'll talk about that. So for example, if you are handed over a patient with a particularly high potassium, then an ECG is something that you will almost immediately want, and you want that patient cannulated. That's something that you can scribble down as a reminder for yourself. Other things that some people like to do is highlight particular observations, or if it's a general clinical history in which you're given something like a presenting complaint of chest pain, then perhaps scribbling down the key differentials that you don't want to miss throughout your ATE and throughout your presentation. If you spend the whole time writing all of your thoughts, in my opinion, you won't be able to order those thoughts ahead of your presentation. And also, because of the speed of the interview itself, there will be no time to look through your notes really throughout the interview. You could pause, but I'd advise not doing so. Another useful tip that we weren't aware of when we went into our interview is the fact that you might be given this 15 minutes to prepare, and then there might be a long wait before your interview, throughout which you won't be provided the clinical scenarios again. So if you do write down some brief information about the patients themselves on your own piece of paper, you can refer back to it, because you might not be given that chance. Our advice for prioritizing is to make things nice and simple, A to E with some caveats. So any patient with an airway problem should probably be seen first. Any patient with a new oxygen requirement probably needs to be seen slightly more urgency than someone with abdominal pain. However, there are obvious caveats to that. If someone has had a massive GI bleed and they are severely hypotensive, and you have another patient with a 2-litre nasal cannula oxygen requirement that's saturating well and actually isn't in much distress, then obviously you need to break these rules. But it's a good idea to have that in mind. And always, as we'll say in a bit, it's always patient safety first. So if you're ever concerned about the well-being of a patient, particularly acutely, then that is your first priority. And this is where the interview is somewhat false, in that you will be the F1 on call. However, in this interview, you see the sickest patient first. You won't be telling your registrar to go and see that patient. You will see them. In terms of don'ts, like I said, writing for the whole time really won't allow you much time to order your thoughts. That's just my personal opinion, but that might be different for you. We'll leave the academic stuff after. But also, don't feel like you need to split your time 50-50 between academic and clinical. Personally, I felt far more comfortable going into the interview in the clinical section than in the academic. And also, there's a bit more minutiae that you can get through in the academic section that might take a bit more thought. So, don't feel like you need to split it 50-50. Do whatever you feel fit. And also, that's where your practice comes in. So practice in real exam conditions or interview conditions, and vary how much time you spend on each, and see which way works out. Anything to add there, Dan, to my ramblings?
Not really. I think the things that I remember doing that stood out is I made a note for the clinical station, a list of maybe, I think there was 5 or 6 things that I definitely wanted to say, because I thought that they were important bits of management or investigations that I thought would demonstrate that I was being safe. So I made a list of those as key things to say. And then basically, as Jack has said, I think the main difficulty with the time you have is thinking about how to prioritize them and how will you justify that, and then moving on to investigations and stuff. If you're lucky like me and you have a really big gap, so I had about 2.5 hours between seeing my prep stuff and actually being interviewed, I made enough notes that I could talk through my ATE approach for the different patients in that time. So I suppose the upside of going in very quickly is it's all fresh in your head. But if you do have a wait, you obviously have to optimize and make kind of best use of that time. And you can do if you make notes and you're prepared and aware that you might have a wait. Okay, so
I suppose actually, thinking back, both myself and others that I know that did relatively well in the interviews applied that approach. So for each one, I wrote down every single relatively common life-threatening condition that I thought that presentation could reflect, and made it my task throughout the A2E to at least address them or rule them out. And similarly, for the patients that I knew it was unlikely I was going to see, have at least one action that I ensured that they were going to be safe, even though I didn't see them. So, for example, if that was a patient that had a new oxygen requirement and I couldn't see them, I was at least going to ask another member of my team to see them, or state clear information to the nursing team about what needs to be done. So, for example, if this patient continues to desaturate whilst on nasal cannula, please escalate to whether that be simple face mask or 15 litres non-rebreathe. And if you are concerned, put out a MET call. And in that way, I've safeguarded the patients that I wasn't going to see. And I can say that in 10 seconds in my interview to demonstrate that I'm going to be a safe F1 that's under pressure at times. That was my approach.
all right, let's move on from that.
Okay, so we've kind of spoke about this. So the interview itself is going to be split 10 minutes between academic and clinical. And the clinical can be anything from one patient with typically one distraction to several patients or several scenarios that require you to manage the priorities and manage them. They'll typically be, from speaking to previous interviewees, there will be at least one distraction. And that might be an angry family member that wants to interrupt you, or a patient wanting to self-discharge, or a nursing team on another ward particularly upset about managing a patient that is agitated and being aggressive towards them, or even in the more severe cases, a cardiac arrest. And the point of this is to demonstrate that you can think on your feet and adjust your prioritizations in response to a dynamic scenario, which you will be asked to do out of hours on call. So it's quite a good reflection. And typically, I suppose probably to make it fair and to test you as a rounded practitioner, you'll be asked at least one ethico-legal question, whether that be related to the patient that you've done your A2E on, or another situation in which you'll have to apply the guidelines that you've learned throughout medical school, and also exercise your judgment. And we've got a bit of tips to how to deal with that in a little bit. I suppose the only other thing to say is, some people say their interviewers interact very much throughout the clinical scenario. So if you ask them for observations or response to your interventions or investigation results, they'll give it to you. Other people have said that the interviewers sit there and blank look them in the face. As far as we know, there's absolutely no reflection on what they do and how well you're doing. So don't be unnerved if someone sits there and looks at you blankly throughout. That's not a reflection of what you're doing. That's just their approach to interview style. My personal advice, and this is very much personal opinion, I interacted with the interviewer throughout. So I asked specifically, for example, if I got to my D in the A2E section, I said, I've put on 15 litres. Have I noticed a change in the saturations in response to that? And my interviewer did respond and say, at this stage, no, there's been no change. Please carry on with your A2E. They might not respond to you at all. I think you'll get a feel of that for example. Anything else, Dan?
No, not really. I think the other thing to realise is that, based on similar or previous interviews, there's 1, 2, or maybe even 3 patients you kind of need to say something about, as well as expecting that you're going to have maybe some questions as well. So if you spend all of your time and you practice to spend a whole 10-minute period talking through one A to E approach, even if you could get maximum marks on that person, you won't fully kind of cover all the bases for all the different things they're looking for in the clinical station. So I would be looking at bringing down the time you spend on an A to E, make it nice and smooth and slick, so you have plenty of time in the interview to interact with the interviewer and to answer any questions they might have without them pressuring you to stop and then move on to the next bit.
I agree, and I suppose I'd caveat that by saying that you're all, like we said earlier, absolutely fantastic candidates. By the time you get to your interview section, you will all be amazing at reciting an A to E. The difference between someone that's good at interview and exceptional at interview is the ability to adapt your A to E and what you focus on based upon the patient presentation and interpret whatever information you're given within the context of a pressured interview setting. So I suppose a baseline of where you should be a few weeks before your interview is to be able to rattle through an A to E in several minutes comfortably. I suppose with the caveat that you will be given several patients, most likely, there is no expectation that you should see all of them and do an A to E in all of them. One comprehensive, in my opinion, is far more beneficial than doing 3 poor A to Es with poorly managed patients.
Yeah, completely.
Yeah, Dan, do you want to? I'm getting sick of my own voice. Do you want to talk through this?
So I think one of the ways of making sure you're covering all the bases and being safe, which is I think the key thing you're trying to demonstrate in this station, is making sure that you can adequately prioritize all the patients. And to do that, you want an SBAR handover with key observations and in an actual trend. So you might get given a blood pressure of 102, but then you say, is that a big change? And they say, no, they've been like that for the last day or so. So you're immediately a little bit less worried about that than if you were given a blood pressure that was 102, but they're normally 160, for instance. You can safety net everyone you don't see, and you can mention that, how you do that. So, for instance, if they have immediate concerns, to call to get back in touch if there's any change, or also using members of the multidisciplinary team, so nursing team, to say, can't go and see them now, but can you do these investigations? Or I would ask for these investigations to be done in my absence, like an ECG, for instance, or to place a cannula, or to take some bloods, or to repeat observations. And that means that although you can't go to see that person right now, you are making sure that you're doing something in your absence. So if they become more unwell, there's a mechanism of you finding out and being able to reprioritize. Anything you want to add, Jack?
No, I suppose apart from the only thing is there's absolutely no benefit in you trying to demonstrate that you can do everything on your own, because that's just not realistic of real life. And I think, based upon speaking to others and look at my own mark scheming, etc., that they really are testing your ability to understand how things happen in real life and how effective you're going to be in real life. And in that sense, there are so many things that we don't really touch upon in medical school that you understand as you start the job. For example, the abilities of the staff on the ward when you're out of hours to do things in your absence. So for example, if you need key investigations, it's quite beneficial to ask for that on the way to seeing the patient. Whereas in real life, it will make you just a much more effective doctor. So for example, I struggle to find a ward here where there won't be at least a few nursing staff that are far better at bleeding patients than me, far better at cannulating patients than me. Like I said, I referred to the same example earlier. If you've been handed over a patient with a potassium of 6.5, you're going to ask for things immediately. So an ECG can be done before you're there. That patient can be cannulated before you're there. And then essentially your job is to assess them and decide, are we going to use some insulin depth? Are we going to give some calcium gluconate? Knowing that things need to be done away from the MCQ of a medical school exam where you're just going to press the button with the drugs and assume it happens immediately makes you far more, it's more real life in this situation. And I suppose the final point on that slide there is really important. Bravado as an F1 is a dangerous quality. If at any stage you are concerned, stating that you want a senior to review the patient, or a met call, or a peri-arrest call, or if you're in a DGH that only has crash calls, to do it immediately is a good thing, is not a bad thing, and that will come across well in your interview. So if you have a patient that's already on 15 litres and is desaturating, what on earth is an F1 going to do in 10 minutes time to resolve that situation? I'd already be asking for a met call, and I think you can do that in an interview and it will demonstrate well. So escalate early as you would in real life, demonstrates that you're a safe F1 and that you're going to be good in AFP where you have less time clinical exposure. That would be my advice for that section, personally. And I suppose the only thing is, for all of this, it's going to be basically a script. So as soon as you get into your interview, you can say, I'd ask for an SBAR handover, I'd ask for observations with trends, I'd ask for a bit of background history, and I'd ask someone to be with me by the bedside. Whilst I'm traveling, I will answer these things, and I will explain to my registrar and my SHO and my on-call team that I'm going to see this patient and to ask if they want me to continue to see this patient or see anyone else. You can say all of that in 30 seconds, and you've got some really good information and demonstrated to the examiner that you know how to approach the situation and how to prioritize patients. Yeah, I think.
Yeah. Someone just asked on the comments, how would you go about asking for an SBAR handover? And I think you literally just need to state that you would ask for an SBAR handover and ask for observations. You don't need to break those things down necessarily.
No. So you'll be given a line of information. You can say at the start of your interview, for all of these patients, I'd ask for an SBAR handover because this is really useful information, but really it's inadequate for me to prioritize these patients. Sure, a patient using at 7 is great. You might be given that information, but without the clinical background and without knowing the trends and those observations, you don't know if this is someone that has been stably unwell for a week in time with the medical team happy with that, or someone that's gone from a news of 1 to a news of 7 quickly, and really you need to do something about that. So I, for all of them, just say, I'd ask for an SBAR handover, and these trends, I'd ask for trends and observations as opposed to single finite information. So that's how I approached it. So this goes without saying. So if any time there is concerns, your priority should be around patient safety. So like I said, if you're worried about a patient, verbalize what you do in real life. You'd ask for, ask for the big doctors to come and help you out, or put out a medical emergency team call. And prioritization should follow this. Much like real life, the distractors will come in your interview, in that you might be asked by a nurse in charge, this patient, really needs a TTO and they're going to be discharged tomorrow, or this family member is furious, or this patient is, very agitated. That doesn't trump your unwell patient. And the point of those questions is to demonstrate that you can prioritize based on patient safety. And you can say, I'm really sorry, but my priorities lie elsewhere at the moment because of these reasons. So that if there's one thing that I keep in my mind, I'd always say it's about patient safety, and they want to know that you're safe practicing F1. Again, considering that if you do an SFP, you will have less clinical time because of your academic block. Okay.
I feel like we've made
Next slide. We've frozen.
Oh no. We're back.
We're back. Good. I think we've largely spoken about all of this, so you can, for all of it, you can expedite your information. You can ask for stuff to be ready by the bedside. If you think a patient's going to require a cannula, you can ask for that to be by the bedside. We've spoken about MET calls. I'd say verbatim, regardless, you can say, as I'm going to see these patients, I will be communicating with my out-of-hours team and my senior registrar to let them know what I'm doing and see if they want me to do anything differently. Escalation status should be something that we all do for all unwell patients regardless. And I think it demonstrates actually in your interview that you've spent time on placement as opposed to just asked MCQs. And it will very much, not that I've heard this happen in an AFP, but you would look quite silly if you do an A2E and do loads of resuscitative measures to a patient that has a ward-based level of care and is on a palliative care pathway. I think it demonstrates an awareness of how things happen in real life. And we've spoken about the MDT is really important, and we've spoken about your levels of confidence. My advice would be that in your interview, you should not say anything that you wouldn't really do as an F1. For example, at the extremes, if a patient requires intubation, you are not going to be tubing a patient out of hours on call. And I think demonstrating that you are aware of this in your interview can only come across well. So, I'm with a really unwell patient at the moment, and actually I feel somewhat out of my depth. I'm going to implement these measures after this A2E, but really I need seniors by my bedside, and that's why I'm going to put out a MET call. Do you agree, Dan?
Yeah, I completely agree. I think that I definitely this interview at the station, but actually life as a junior doctor, a huge amount of it is recognizing who people are and escalating them, and not about coming up with some incredible house-esque diagnosis at bedside, doing 108 things by myself. It's definitely about spotting people who are sick, going and seeing them, checking them, telling my senior, escalating care if needed. That's basically what the job is, and that's what the station's trying to check.
Yeah, and actually, now being in this, being an F1 on call, I think it's actually very good preparation for what you're going to experience out of hours. So yeah.
So let's move to a real life example. So
Go on, Dan.
Bit of audience interaction. If you take your phone and scan that QR code, it will take you to the Enti website. And I just want you to all read through these descriptions. These are all clinical vignettes of patients. These are very representative of the sort of thing you might be given. And just go onto the Mentimeter and prioritize them.
Yeah. So which patient do you want to see first? I'll give you a couple of minutes.
And whilst you guys are doing that, I'm going to just talk very quickly about some comments that people have posted as well. So someone asked, could you explain more about treatment escalation status? So treatment escalation status is a bit more of an extension to DNA CPR. So DNA CPR is basically someone is either going to have CPR or they're not going to have CPR. Whereas treatment escalation status is an increasingly widely used concept, which is not just about whether someone would be for resuscitation or not, but for whether someone is suitable for treatment in intensive care, whether someone is suitable for IV antibiotics and fluids and things, or at the lowest escalation status would be for this ward-based care, some treatments like oral medicines, or then I suppose the next step down from that is a palliative comfort-based pathway looking to treat this person symptomatically only. And then someone else has asked, if a patient comes in with septic shock, would you put out a met call straight away or give fluid resuscitation first? So I think that really depends on how unwell that person is. So if someone was, I thought someone was septic and they had a bit of a low blood pressure, then I would think about giving them a fluid challenge. If I had one of these patients and they had a systolic of 50, I wouldn't even think about touching fluids. I would be calling for a met call or peri-res call to get, more qualified, more experienced people to the bedside first. And then whilst they're coming to me to come and help me, then I can worry about things like fluid. But I wouldn't do that if someone was stably unwell. I think there's kind of nuance there that determines how you're going to do those things. Jack, do we have some answers on the Mentimeter?
We do. It's coming up well. I think we'll call it that. Do you want to show everyone or should I read it out?
If you read it out, I don't know how to.
Okay. So we've got 5 for hypokalemia patients. We've got 37 for our tachypneic patient. We've got none for our frustrated family member. And we've got none for our surgical patient. I think it might be useful actually if someone, again, audience interaction to save my sanity, someone that chose patient 2, do you want to pop in the chat why you chose patient 2 in the first instance? Might be a good way of approaching this, and then we can talk through how we're going to do it. Tell me if there's just complete silence.
Yeah, I will do. So anyway, so someone's put most acutely unwell patient, which I like, but I want to know why. Why are they the most acutely unwell patient in your opinion? Cool. Okay, so answers I've got, I don't know whether you can see them here, Jack, but I've got some good
Can't see anything.
So I've got low SATs despite O2. I've got Tanya saying it's a B issue, desaturating on O2, tachypnic, declining GCS. And Lana agrees as well. So it's a B problem, which is a priority here. And someone else also said, yes, also said 92% on 10 litres of oxygen. What do you think, Jack?
So firstly, yeah, I think no surprise that you've both identified 2 acutely unwell patients, and I'd be going for 2 for the reasons you've talked about. So we've already know that we're giving this patient 10 litre simple face mask, which is, I don't know, trying my conversions FIO to something like 0.5, and they're still not reaching target saturations for someone on a scale 1, or basically a non-hypercapnic patient. We know they're tachycardic as well. So basically, that's an acutely unwell patient, and for that patient, I'd already be thinking about putting out a MET call. The first patient, sure, is unwell. There's potential risks there for arrhythmias, for example, but actually all of their observations are relatively stable. We only know it's one single serum potassium value, and generally there's no other concerns. Although, for example, if we were to get an SI handover and we would say that this patient is experiencing palpitations of chest pain, that might change it somewhat. In terms of patient 3, ongoing abdominal pain, sure, might be an indication of an acute pathology that we're concerned about and need to do something about. But actually, the pain's 2 out of 10 in severity. Their observations are all within normal range, and it's very hard that there's a frustrating family member there. But going back to our patient safety prioritization, that doesn't trump the fact that we have 2 potentially unwell patients. Patient 4 I put in there for several reasons. Firstly, because it's not unlikely that you'll be given an aggressive, delirious patient, and that can be hard to manage. And we're all well versed in our management of that throughout medical school in terms of good nursing measures, reversing the reversible causes of delirium, and at a last attempt, potentially using some pharmacotherapy. However, it's important to consider that delirium itself may be a symptom of an underlying pathology. And I think demonstrating that lateral thinking in your interview demonstrates that you're aware of all those things. So that's how I'd approach it. I'd actually go patient 2, patient 1, probably patient 4, and then patient 3. And then thinking back, I suppose we're going to potentially do it later depending on time, but thinking back how I'd safeguard these patients. So for patient 1, as we previously spoke about, there's several things that I need there. In addition to communicating it with my team. So that person is almost definitely going to need a cannula if they don't have one already, if not 2. Preferably we'll have a repeat of that potassium, and knowing how that can be done fast in a hospital is good. So a VBG will come back quicker than a lab value. And based on your trust guidelines, it's more than likely that this patient is going to need an ECG. Those are 3 things that I can ask from ward staff that does not require my presence. However, things like interpreting the ECG will require a doctor to go and see that, but we've got something in the interim. And I'd also say I'll communicate that with my seniors to make sure that that patient's seen whilst I see patient 2. In terms of patient 4, you can ask for several things as well. So observations would be good for this patient, although it might be hard considering they are throwing things at the ward staff. You can give advice about general nursing measures, reorientate the patient, for example. And then say, if you are concerned, please call me back. In terms of 3, again, SI handover, trends and observations, you'll try and get to it in the interim. If there's any people within your team that are 3, then that can also be a good thing. Also, the history here is very, very important, and we don't have much, so we can ask for a bit more history. For example, is this a post-operative patient that has new ongoing abdominal pain? Or, for example, is this patient, because they might be delirious, have they just not taken their analgesia for the day? You're probably not going to get that information, but saying a couple of things for all of those and how you're going to safeguard them is going to look really good in your interview. And although I've laboured the point here, you can do that in about 20 or 30 seconds. But yeah, no surprise that you got that right. It might be more nuanced in your interview. And the point we're trying to make is you just need to justify why you're doing what you are, and that you're ensuring that every patient is safe if you can't see them immediately. I suppose for patient 2, the only additional holding measures I can say is, please put that patient on 15 litres non-rebreathe. Sure, they might be a retainer, but we can deal with that in the interim. They are hypoxic at the moment. And if they desaturate further, then please put out a medical emergency scene call if you choose not to yourself. Those are things that you can tell on the way to ensure that the patient's being safe, because they might get the other side of the hospital and it might take you 5-10 minutes to get there. Anything to add, Dan?
Not really, no. I think it's very fun. I like describing things as a problem or an airway problem or a breathing problem or circulation problem and prioritizing that way. I think we're all taught A to E. The people who've been marketing will be well versed with that as well. So it's a universal language, use it to your advantage, and it will clearly help you prioritize and justify why without having to use a lot of words. Someone has asked if you can ask nurses to carry out examinations. I would say essentially the bottom line is no. The role of a junior doctor is you're going to go and do the examinations with a few caveats. So I suppose you could ask someone to do a bladder scan, which is almost an examination. You're scanning their bladder to see if it's full of urine, but it's not really an examination. And you're not going to ask them to kind of check for retention or constipation or do a PR exam or anything like that. I would not, just to stay on the safe side, I would not ask any nurses to do basically any exams on any patients in this clinical state. Literally, just as blur the lines that you may not necessarily know what your role is going to be.
Yeah, no. And actually, I kind of triggered another thought in my head. So now almost every hospital will have a critical care outreach team. And it's good, before your interview, please look up what all of these teams mean and do, because actually it demonstrates that you know how a hospital works. For patient 2, certainly they will meet criteria for a critical care outreach team referral, who will see the patient and be far better at managing them than you as an F1. And they will predominantly be run by critical care nurses, plus minus registrars and consultants. They will do some examinations. So there are caveats, but for the interview, I'd say no, with the exception that know when you can escalate to CPOP and verbalize that in the interview, because they are a fantastic resource. 1, for initial management, but 2, also if this patient is going to go to ICU, they have direct lines of communication with ICU and will be communicating with the ICU team already. So knowing what they do and how to use them will actually come across really well.
And then second follow-up question, someone asked, can you ask the nurse to treat without assessing in the context of O2, of oxygen? If someone's desaturating, they don't need a junior doctor to come over and say, yeah, that person's definitely desaturating. If someone's desaturating on an O2 stat, give them oxygen. Best treatment for hypoxia.
And actually, particularly, I don't know where you work, Dan, but the nursing teams here are fantastic. They will have probably already done so by the time they contact you. Particularly if it's prescribed, but often if it isn't as well, they'll just do it.
Yeah. And then someone has said, just another question. Do some judging. Is there any scenario that would recommend doing more than one full A2E assessment? I think it's not so much. I mean, in real life, you would do a full A2E assessment on all of these people, but for the time limit you have of the 10 minutes, you have to think about what you're going to be able to realistically do. You're probably going to be able to say that you're going to do a few things before you see people, do one thorough A to E to show you know how to cross all the T's and dot the I's, and then you're going to do probably a follow-up of a couple of others, other patients who you can see and say a few key things you would do for them, and at that point they'll stop you and ask you some questions and stuff. That's how I think about it. In reality, when I see patients, I don't say, I've only got 10 minutes left on my shift, so I'm just going to do a quick A to E on this person and then go off and document. They get a full A to E every person I see.
And you might be interrupted throughout, and that's fine, and then you need to reprioritize. But my advice would be practice this loads, and you will soon realize that doing more than one A to E fully is going to be challenging. And so you need to probably reconsider how long you are spending on it and what you are considering. All right.
A few other questions. We will answer these at the end, but I'm just aware that we have a time limit ourselves, and so we must move on. So let's move on. Okay, so I think we've covered these things, but just to definitely clarify, don't expect to see everyone. Don't state you'd act independently or without support of a senior. Don't say you do anything that's beyond your competence. You're not being a hero in the station. You're trying to demonstrate you're the most person ever. Don't leave a patient without safety netting, and don't prescribe anything for a patient who you don't know their medical history, allergies, and current medications. If you say you're going to give penicillin to someone or amoxicillin or whatever, and then the interviewers give you a nasty little twist and say, whoa, but they're penicillin allergic, that's going to really throw you off and throw you off your flow and not going to look great. So make sure you know a little bit about these things before doing them. But the vast majority of this station is about the assessment of the bedside and what you're going to do in steps and steps and steps. So if you're getting onto the 5th line management of asthma, you're probably doing it wrong. It's not about that. It's about talking about how you prioritize, how you be safe, the investigations you ordered, and the first simple, effective, and important medications you're going to give immediately. Anything you want to add very briefly, Jack?
No, I'd agree. I mean, there are obvious exceptions to every rule that we say. So if a patient is obviously having anaphylaxis, then IM adrenaline is probably fine. If a patient is acutely desaturating, then you can probably put some oxygen on them, and fluids we put a question mark there because obviously they might be overloaded, etc. I suppose leading on to Dan's point about 1st line, 5th line management, this isn't an MCQ, so I very much doubt you will be expected to know management further down the line. But actually, a lot of good candidates will know dosages for emergency medicines, which will be useful. And my advice has always been that if you think in real life you will not have time to look it up, which is actually a very small amount of drugs, then you should probably know those dosages going into your interview. Apart from that, everything's a bonus, in my personal opinion.
Yeah.
And that's how I approached it.
Something that I can say just as an exception between the difference between a London interview and an outside of London interview I had, which was an interview at Cambridge, was they expected me to know dosages. You're right to a degree that dosages vary between trusts for some drugs, but they definitely don't vary for things like adrenaline. Everyone gets the same dose of adrenaline, probably on the planet. Everyone gets the same dose of adrenaline. So things like adrenaline and like nebulizers and stuff like that, just know the dose because it will be useful for your interview, but also you'll be expected to know this as a doctor.
Yes, exactly. Things like anything on ALS guidelines does not really vary. Nebulizers, for example, you might have a difference in salbutamol. If some trust 5 mg to 2.5 mg, it would be a really harsh interviewer that was to mark you down because you weren't. That's just not going to happen. But ballpark is certainly important, and if it's on emergency guidelines such as ALS, then those are your dosages. So ideally, just know them.
Okay, let's move forward.
Yeah.
Okay. We talked about all of these things, I think.
Kind of. So the idea of this slide, we said earlier that you should probably know. We mentioned all of the life-threatening causes. So there's life-threatening causes, there's life-threatening presentations, there's general presentations. And the way that we approached the interview was to basically think about all of the common presentations that you see in hospital, whether that be shortness of breath and chest pain. And for all of those, think of all of the life-threatening causes as a safe F1. Life-threatening causes being, the most common causes, not the very niche 1 in a million causes. For all of them, we wanted to know, 1, what are the life-threatening causes? So what are all the life-threatening causes of central chest pain? And 2, that we should probably be able to instigate basic investigation and management of them out of hours. So if you could all, let me see if my Menti's working.
So scan the QR.
Use that, scan the QR code, and then just put in there a common presentation or a common life-threatening cause that you might see out of hours, just as kind of a thought exercise that may or may not work. And again, we'll give a couple of minutes and we can look at the chat in the interim.
All right. So let me go back and answer. Would I prescribe? So just to answer a few other questions. So someone said, would you prescribe analgesia before seeing a patient or until examination? So I will say, whilst it is very tempting to just, I'll prescribe the analgesia, they're good to go. I think it's important to ask, why is someone in pain? Has their pain changed? And the only way you're going to know those things is by reading through their notes, going and seeing them, examining them, and then prescribing. So, they might already have paracetamol in their drug chart. So if you say, I would just give them some paracetamol, and then they say, do you know? Oh, you know they're not on paracetamol or something. That again is going to throw you off kind of your smooth flow. So I would think about not doing things for people you've not seen or don't know. Everyone in theory gets a review of their notes. You go and clinically examine them, ask some questions, and then you prescribe the things they need. And then someone asked, do you think it marks you down to not know doses? I think it's fair to say that, if you get the worst case scenario is you get the dose wrong and you get the dose dangerously wrong, that's going to mark you down because that's unsafe. If you say, I don't know, but I would check in the BNF or I would check with the trust guidelines, I think that is a safe middle ground area. No one can mark you down for admitting where your competence level is and that you were doing the safest thing. But obviously the best or most optimal mark is saying, this is the dose, but if I wanted to double check it, I check here on the trust guidelines, because you're saying, yeah, I know exactly what the dose is and I know how to double check it.
Great.
Okay,
we have are you able to show this, or do you want me to read out again?
I don't think I can show it.
That's fine.
Easy way, sorry.
I think it will come up on their own one anyway. So things we've got are pneumothorax, anaphylaxis, chest pain, PE, sepsis, about 1 million shortness of breath, hypoxia, tachypnea, intracranial bleed, seizure. So hopefully you can all see this. If not, maybe let me take a quick screenshot and we can share it later.
Yeah.
But essentially what this demonstrates is that you all probably know the common causes of potentially life-threatening illness in the hospital. Our advice, or the way we approached it going into the interview, is for all of these, I need to know the most dangerous causes, and I need to know how to resolve them. Only at a first line, maybe at a second line if you're particularly comfortable. And if you do that, you're really not going to be asked very niche diagnosis and management in your interview, because that's not the point. The point is that you're safe at managing what you will see. So good rules of thumb here are, if it's in the Oxford Handbook, emergency medicine section, or the section at the back, whatever it is, you should probably know it. And there are other resources that we'll share later. That's how we'd approach it. And for all of them, the way we approach all of the investigations, so throughout your A to E, is if it's by the bedside, do it first. Bloods and gases probably come a bit later, but actually they'll happen throughout the A to E when you put a cannula in. And all of the imaging and complex investigations come at the end if you are able to do them. And I say that by saying that, understanding that you will verbalize in the B section that you might want a chest X-ray. However, asking for the results of that chest X-ray immediately demonstrates that you probably aren't aware how things really are at hospital, and actually you'll realize that the priority of that might change somewhat. So if a patient is acutely hypoxic, a chest X-ray isn't going to fix that, and actually it'll take some time to come. Similarly, if you want for example, if a patient has some signs of ischemic heart disease and they've had, previous normal ECGs and TROPs, asking for a myocardial perfusion scan in your interview, whilst demonstrating that you have some kind of background cardiology knowledge, actually demonstrates that you aren't really aware of what will happen out of hours and how you will approach these patients, because it just won't happen. So I think that's the key difference between the MCQ that you're going to get in your medical finals and this SFP interview, where you're expected to know how things work and how you're actually going to act. So I think when I was practicing for my interview, think about how this is going to happen in real life, and how am I truly going to respond? And it might be a bit late to do this, but if you are on placement at the moment, actually shadowing one of the F1s or F2s or SHOs out of hours is really, really useful to see how it really happens. And we've spoken about all of the rest of that, I think. Anything to add there, Dan?
No, nothing to add.
Good.
Let's back on.
Yeah, keep going.
So really, ethical legal areas, expect these sort of things to come up. So you want to make sure that you've definitely had a read through them, but also that they're fresh in your head. So things like capacity, consent, guilty competence. How would you deal with violence and aggression? Jehovah's Witnesses, blood transfusion. What blood products can Jehovah's Witnesses sometimes have, or what will they potentially agree to, or what alternatives are there, and how would you navigate that? Mental Health Act, so Mental Capacity Act versus Mental Health Act, and deprivation of liberty safeguards. You're obviously not going to be expected to know the granular detail of each of these different areas, but knowing where your competency lies, in a lot of these cases that you're not going to be the person to make that decision, but you know who the person to make that decision is, that you know how to provide support to patients, and you know how you would find out more information and get more support about all of this. So I think we should move on, Jack. We touched on these things really quickly, but I think for time,
I
think
completely agree.
I'll answer some of these questions afterwards in a bit. So
yeah, I agree.
Again, very briefly, how to prepare. So Oxford Handbook of Clinical Medicine, in that back section, all the pages in red, read through all of them, make sure you know them, I would say almost inside and out, apart from the kind of weird niche, Addisonian crisis things. I think you should know all of the really common ones, and it's got some really good ways about looking at differentials for things like shortness of breath. Handbook of Foundation Program and the Handbook of Emergency Medicine are also fantastic as well. ALS and Resus Council guidance, National Society guidance, so individual societies, so like knowing the acute asthma guidelines for treatment as by the British Thoracic Society is definitely something worth looking at, because it will just talk you how to manage an acute asthma exacerbation. And then the GMC has lots of really useful documents on how to navigate ethical scenarios and problems with patients. And then I suppose the other tip is that you need to practice and practice and practice until you're sick of doing it. And it does get very boring. You need to vary your practice. So do practice with other people, but don't just practice with the same other person, because if you are missing things out, or you do have kind of habits and things that aren't necessarily the most helpful, you'll just reinforce them if you only practice with the same person. Be harsh critics. So me and Jack practiced with each other, and we were extremely, I think towards the end, very nitpicky and very pedantic over how we were presenting things and what we would do, and how could you be caught out by an interviewer by giving that answer. But actually it meant that when we got to interview, I don't know about Jack, but I felt that the interviewers gave me an easier time than Jack had done like the day before. So it felt a much easier, more comfortable place to be than, the other way around. Don't practice and compliment each other and have a really hard interview day. And then, as Jack said, actually shadowing F1s and F2s out of hours to see how these things work. Even if you can't verbalize exactly that, it does come across in interview when someone has seen and has experienced what an emergency looks like compared to someone who's just read about it, I think. Anything to add, Jack?
No, I think that's literally how I prepared. So I took those resources, I created flashcards, and for several months before I made it my duty to basically learn them rote. And then, we had a group of several of us where we rotated practice, and I'd say very much vary your practice. So practice in a situation where your interviewer gives you nothing and just sit there and just deal with that uncomfortableness. Interrupt each other, sometimes provide results throughout, sometimes don't, so that when you come to your interview day, when you're inevitably very well prepared, but the anxiety very much kicks in, most of it is just you've done it so many times that it's natural, and you can free up the brain space to interpret the information you're given. If you're having to think about your A2E and the components of an A2E on interview, by the time you're given the information, I very much doubt that you have the capacity to then interpret that information and adapt your approach. So that would be my recommendation there. There really isn't enough practice that you can do for these interviews. And I promise you, so a large proportion of you won't get AFPs. It is absolutely not wasted time. Almost every one of you will get a medical emergency in your finals that you have to deal with. You'll see loads on call, and it was probably the best practice I did in the whole of final year to make me a better F1 without doubt. So it's not wasted time at all. So yeah, my advice would be just to do it.
Okay.
So what do we reckon timing wise?
I think
we could do it.
Should do it. Should do it.
Yeah. Okay. So
should we get you to talk one?
So we've spoken about prioritization. Should we, for example, get me to do one A to E, and then we'll stop at some point, and you can do whatever. Okay.
I'll stop you. Okay.
So as we've said before, we've already prioritized these patients, and we've spoken about. So if I was to approach this interview, I'd say something like, so here we have 4 competing priorities, 2 of which I know are acutely medically unwell, or at least their lab value in the case of 1 suggests so, and the observations in 2 suggest so, plus minus 2 other competing priorities, which might suggest medically unwell patients. So there are things that I'm going to do to safeguard all of these patients whilst choosing to see patient number 2. For patient number 1, I'm going to ask the nursing staff, can they cannulate this patient if they don't have one already? Can they get an ECG of this patient? And if anyone on the ward is able to bleed the patient, getting a VBG plus minus repeat bloods would be really useful to know about that potassium. I'd also clearly state to them that if this patient becomes symptomatic, whether that be with palpitations or chest pain, for them to immediately call back, and if they're concerned about medical emergencies or peri-arrest, I'll be communicating with my team to find someone to see this patient in the interim. And patient 3, I'd be apologising to the family member, or getting the nursing staff to apologise to the family member that I'm dealing with medical emergencies at the moment, so I won't be able to see them. Again, explicitly stating to the nursing staff, if they're concerned about that patient, to call me back. In terms of patient 4, I'd like to see that patient because that might be indicative of an underlying pathology getting worse. However, that is not my priority at the moment based upon the information I'm given. I'll advise them that generally reorientating the patient and good nursing techniques will be the optimal approach. And then potentially, if that doesn't work, once we've ruled out these first causes, we might think about pharmacotherapy. So I'm going to see patient 2. On the way to patient 2, I can ask the things. So this patient is going to need cannula. So I would ask cannulation and blood and gas equipment to be by the bedside. I'd like repeat observations, and actually I'd like ongoing monitoring. So please leave the blood pressure cycling, please leave the heart rate and saturation running, and potentially a free lead depending on where they are at the time. I'll also ask for a nurse to be with me by the bedside, and hopefully someone that's aware of the patient history to also be by the bedside with me, plus minus with patient notes, depending on where I am. On approaching the patient, I introduce myself. I'm the F1 doctor, and in doing so, I'd be looking at the patient to see if there's obvious signs of respiratory distress or generally unwell. I'd assess if they were communicating with me to let me assess whether their airway is patent and if there's any additional signs. In doing so, I'll also be having a brief assessment of their GCS. Depending on, please interrupt me if you have any information to give me, Dan, but otherwise I'm going to assume that everything I say is negative findings. So, for example, there's no additional airway. Because of this patient desaturating, I'd like to put them on 15 litres non-rebreathe immediately, and I'll be considering the risk of hypocapnic respiratory failure, but at the moment hypoxia is the greatest life-threatening cause in this patient, or life-threatening problem in this patient, so we'll go with high oxygen and we'll titrate down. I'll assess that their trachea is central, and with consent, I'll expose their chest and have a look at their chest. Things that I'll be looking for following my hypomnemonic will be that I'll inspect the chest, I'll look for signs of respiratory distress, I'll look to see if the chest is rising bilaterally, And if the patient is evidently working hard, obviously I'll also be looking for any signs of peripheral or central cyanosis at the same time. I'll press the chest, I'll auscultate the chest as well, and I'll assess the bilateral expansion. We've already put on 15 litres, so at this stage I will relook at my saturations to see if that has changed at all in response to my intervention that I put in place in the first place. This patient, because of the fact that they have such a high oxygen requirement, they will require a gas. So I'd be looking for the team around me to see if anyone could potentially do an ABG, and if they can't, I'd ask for the equipment because I know that I'm going to need that. I'm already worried about this patient because they're on 15 litres and desaturating. So actually at this stage, or if I haven't done it immediately, I'd be using either my medical emergency team or my CCOT, all depending on what kind of hospital I am, to get more support with me. I've already let my registrar know that I'm seeing this patient, so hopefully senior support is coming. So I think that's my B section covered for now. Moving on to C, I'd be looking at the blood pressure and heart rate again. I've already asked for cannulation equipment, so again, I'd be asking ward staff if anyone can cannulate with me, and if so, I'd like 2 wide bore cannula in each ACS, and in doing so, we can take off bloods. I'll do a standard panel of bloods, including FBC, CRP, UZNEs. If I'm worried about a PE, I may consider a D-dimer, being aware of the issues with that. I could do a clotting and I can get a gas as well. If I'm concerned about which blood test I might need at the same time, I can take off the syringe and think about it after when I get more support. Looking at the blood pressure, actually, I'm happy with this at the moment. So I'm not going to start fluid therapy, although they are tachycardic. I'm going to check peripheral and central capillary refill time, which might guide me in my understanding of whether this patient is shocked, and also the lactate that I get back will give me some more information, but I'm not going to initiate any issues at this stage. Because they're tachycardic and considering the resources and the team I have around me, I may be considering an ECG, although understanding that this is quite resource intensive, so if not, we'll get one immediately after. I'll also have a listen to the heart as well. And like I said, if we're in a monitored bay, a 3 lead would be really useful at this stage. But again, thinking about where the patient is, that might not be possible at the moment. Moving on to D, I'll use an ADPU and I'll ask for a glucose for the patient. But again, I will be able to get that from my VVG, and it depends on what staffing I have around me and if anyone's able to get the glucose. I'd look at a temperature as well, which might guide me towards differentials at this stage. Moving on to E, I'd assess abdominal pain, and if this patient has passed urine and to what extent they pass urine today, and that might guide me as to whether they're septic or if there's anything of concern going on there. I'd fully expose the patient and look for any obvious bleeding, bruising, or any other pathology that might indicate their cause of their acute deterioration. After doing so, I will review the drug chart and patient history and reassess my A2E, which I won't do now for brevity, but because I've initiated initial management plans, I will reassess the effect of those management plans. This also now will provide me with an opportunity that hopefully more of my team will have arrived, whereby I can ensure that ABG is done and initiate some investigations, such as a chest X-ray, for example. And I'd continue like that.
I think we'll stop there.
I hope that was okay.
So that is an example of an A to E approach, prioritized beforehand. And as you can see, so that took about 5.5 to 6 minutes. So probably by the end of talking through that, with maybe a bit of discussion with the examiner, come to the end of seeing one patient, maybe time to talk about 1 or 2 more, and then maybe any ethical legal things. As you can see, it is hard, and you need to be very well versed with what you're talking through, and you want to be able to talk smoothly through each of the sections, not seem like you're trying to remember what's coming up next, and also being able to give caveats and nuances shows that you're not just regurgitating something, but you're thinking about the patient in front of you and how you're changing your management to fit them perfectly. So let's move on. So that's an example.
I suppose the one thing I can add there to that is what we've said already, is that during my interview, that was very much how I flowed. However, when I asked for those investigations or results, I was given more information. So for example, since you put the 15 litres on, the patient's saturations have now improved to 96%. So like we said earlier, if you aren't well versed in A2E or speaking it, which I'm not as much at the moment, at least speaking it, it can be very hard to interpret that information within the context of your pathology. We also didn't even get onto the potential differentials there. So it's important to kind of park that information.
Definitely.
Yeah.
So this example is actually something that you can find in one of the documents they give you for the interviews and as part of applying to the SFP, or as named as the Academic Foundation Programme before this year. But this is an actual example. We won't make this available. You guys can have free access to this through the foundation programme. But this is the sort of thing that you're expected to talk through and navigate. And as you can see, there are quite a few things here medically and legally that you're going to need to be able to navigate and talk through. I'm just acutely aware of the time. So I think we've given some opportunities for questions, but just in kind of closing in the last few minutes, does anyone have any other questions or things they would just like us to talk through?
So I've got a few here. Sana has said, is it common for interviewers to ask us to interpret things, e.g. and ABG during the assessment? I think I'd prepare as if they can, bearing caveat that if they are going to give you all of an ABG result, that's actually going to take up a lot of your time, and they're not going to be able to accurately assess you. However, they may quickly say that, this patient's PCO2 is 8, which will guide your management. So I'd very much prepare as if they can. Any in-depth investigation they won't give you. Expect that they can give you changes and observations and the immediate things that you can get. So for example, if you had a patient with reduced level of consciousness, it should be expected that an interviewer can at least give you a glucose, because that takes 2 seconds and it completely changes how you'd approach that patient. Similarly, they might not give you anything. So that's how I approach it. But again, these are all things that you're learning for your medical finals anyway. So I wouldn't really stress about learning the minutiae, because you've already learned it throughout medical school, and this isn't about learning new information, it's just about applying that information. I'm afraid I've lost track of what.
I've got a question. So a question, someone said, would you say your differentials during your A2E, or would you say it afterwards? I would say that probably the question, so that's a good question, because it demonstrates actually, although we're learning like almost rote learning a process, it's really important we keep our nuance, and we know that there's not a one size fit. So if I was given a clinical vignette that I thought demonstrated anaphylaxis, I would say right at the beginning, I think this is anaphylaxis, or I'm concerned about anaphylaxis. And I know the things that I need to do immediately are put out a crash call, make sure there's some adrenaline at the bedside, make sure I know where the crash trolley is, get the patient on the bed, and then I'm going to run through my ATA and stuff. But I talk about that at the beginning. If I thought it was something that was less, immediately life-threatening, like a bit of breathlessness in someone who may or may not have an infection, or it's not clear what the differentials are, I talk through my A2E approach first, and then at the end of it, once I've got as much information as possible, I would say, well, my impression is that given they have a fever, they're breathless with a low blood pressure, and I've noticed on auscultation there's some crepitations in the, on the right-hand side of their chest. I think this could be a community-acquired pneumonia. So I'm, as I've said, going to have my mobile chest X-ray coming, and I can look for that. But other differentials I'd be thinking about are, and then maybe layer off a few of them. But I think it's really important to remember the whole point of this station is demonstrating safety and actually making sure you're doing all the steps and investigations, so that when a senior comes, they have all the information that they need to help make further decisions and guide treatment. Is more important than you nailing the diagnosis and saying all the bits of information, all the bits of management that from multiple choice questions you're supposed to say. Because actually, A to E isn't like that, and on call in hospital, I can tell you it's not like that at all. It's very much, I'm treating something, I don't necessarily know what it is, but I just need to do these safe things first.
Yeah, I'd agree with that. I'd say you should know all of the immediately fixable things that you'll see within your A2E and how to fix them, but be very prepared to get to the end of A2E and not know a diagnosis. That doesn't mean that you've done badly. It just actually means that you're keeping your diagnostic sieve really wide, which is good. And the information you're given can help you reorder your differentials, but ultimately you probably won't have a primary differential. And I certainly didn't during my station. There's loads more. It's getting fast. There was one about time. So can I just confirm that within the 10 minutes, we only get the prioritization A to E, or do we get an ethical scenario alongside it? I'm almost certain that you will be given an ethical conundrum, but it will probably be quite small, and it will relate to what you've seen. You won't be expected to, for example, talk about your reasoning behind it and how it will be very much like, for example, I can treat this person because it's an emergency, and even though they don't have capacity and they can't consent, I will do that. However, I will discuss with my senior after, with some caveats. For example, if they are an adult and they are a known Jehovah's Witness with an advance directive saying they don't want blood, that might adapt yours. So I'd say this is where it's really important to know your ethical and legal guidelines that you've been taught in medical school, so you can interpret it quickly, but also bearing in mind that as an F1, the only ethical legal decisions that you're going to be making are the ones that cannot wait for one of the big doctors to come along and help you out. So I verbalized that during my A to E. Okay, I think that should we move on to explaining what everything else is and say we'll deal with other questions later?
Should. So what we're going to do is, tonight you've had a quick run through the clinical station. Jack has taken us through the majority of that. Next week, we're going to look at preparing for the academic station, and how you go about doing that, the experience of it, and maybe questions you can expect. And then there are we're looking to run some mock interviews. 123 people have signed up to watch this through the medal thing tonight. I won't lie, we're not going to do 123 mock interviews. We'll do as many as we have capacity for. We will be, if you email sfp@mindbleep.com, we will reply with a spreadsheet, or we'll get a spreadsheet out, or a Google form.
The spreadsheet link is there, so use that instead.
Use the spreadsheet link, which is, I'll post in the chat as well, and fill out the form, and then we will try and just as many as we possibly can around our work commitments and lifetime. And we've also recruited in some other AFPs who are going to help do that as well. So we're going to try and do as many people as possible.
Yeah, I suppose I'd say if you are interested, tonight is the time to put your name on that, because that's going to guide how many people that we can get. And if you have other questions that we can't reply to the chat, go to the Facebook group and we can reply on there.
Please do fill out the feedback form. It's really, really helpful for us, just so that we can know what we've done right, what we've done wrong. And I hope it's been helpful and useful. And we'll see you next week. And best of luck with the preparation. Anything else to add, Jack?
No, thanks.
Sweet. Right.
Give it a minute so they can all take pictures of the feedback before we.
And this is where it all falls apart. I'm trying to find the link to the. That's the live stream.
Do you know how to do the saving of the recording and stuff?
I think it's all done through the medical site. Cool. Right. Let me. Cool. Thanks so much, guys. I'm going to stop the stream now. And bye. He says, having absolutely no idea how to do that.